I'm going to begin trying to wrap it up. This is going to be one of my last comments about concerns with this practice of treating chronic pain with opioids. This is data that comes from 938,000 urine samples collected by pain specialists treating patients who are on long-term opioids for chronic pain. These are patients who, by definition, would be physically dependent on opioids. And there are different findings here. What I'd like to just call your attention to is the middle bar. And what you're seeing here is that about 38% of the samples they looked at, samples provided by pain patients on opioids, who are physically dependent on opioids, who may be sitting in their doctor's office looking perfectly comfortable, providing a urine sample, but when you look at the urine, there's no opioid in the urine. And you may scratch your head and say, well, how can that be if they're on opioids? If they didn't take it, wouldn't they be in withdrawal? What's probably happening here is that what this really suggests is that there are massive amounts of diversion. Patients showing up in doctor's offices, presenting and complaining of pain, who are not even taking a single dose of their opioid before going in for a urine test, and completely diverting the entire prescription to the black market. And when you understand the black market price for some of these opioid analgesics, you can understand why people would be motivated to do this. In Staten Island here, it's one of the 5 boroughs of New York City where we have a particularly serious problem with opioid analgesics. The street price for a 30 milligram immediate release oxycodone tablet ranges from $20 to $30 for one tablet. And there are patients with chronic pain who are being prescribed 240 tablets a month. And their health insurance is paying for the doctor's visit and paying for the prescription. So, and with a prescription like that, you could certainly support a family. And there are now organized crime rings sending people into multiple doctor's offices to get opioids. If you think about one of the other educational messages, which I did mention, which is that pain is what the patient tells you it is. And if you add that to the other educational messages, and then you think about the maps I showed you that were turning red and the rates of neonatal abstinence syndrome and overdose deaths, and you try and understand what's going on, I think one of the most serious problems here is that we've created a situation where we now have de facto legalization of heroin pills, where all someone has to do to get heroin pills, and I didn't present the data on this, but the opioid analgesics that are prescribed are every bit as addictive as heroin is. All one has to do to get the equivalent of a heroin pill is to show up in a doctor's office and complain of pain. And even if there's nothing objectively wrong with that patient on physical exam, that patient may walk out of the office with a prescription for opioids. And certainly if you are someone who does have something objectively wrong with you on physical exam, you can very easily walk out of that office with a prescription that can then be diverted. So how do we bring this epidemic under control? I think that if we really frame this epidemic, and people sometimes describe it as an epidemic of drug abuse, which I don't think is the correct way to frame this. And abuse is really a behavior. It's not a disease. And even sometimes it's referred to as an epidemic of overdose deaths, which also I think is not quite specific enough. I think that we really should understand this crisis as an epidemic of opioid addiction. We do have people who are dying of overdose deaths who are not addicted, a significant number. A young adult who experiments with an opioid for the first time has no tolerance and happens to experiment with an extended release product in a powerful dose and overdoses and dies. And that accounts for many people who are dying. And there are also pain patients who might be on high doses who accidentally double their dose, forget that they took their dose, and also die of an overdose. But these deaths tend to be, the best evidence suggests, are a minority of the deaths. The bulk of the people dying of overdose deaths appear to be people with the disease of opioid addiction. And they develop that disease either from medical use of opioids or from non-medical use of opioids. So if we frame this as an epidemic of opioid addiction, and we understand addiction to be a disease, then it also becomes clear that at least the first two things that we need to do for bringing this epidemic under control are identical, or really the same things we would need to do to bring any disease epidemic under control, whether it would be an HIV epidemic or a flu epidemic, you name it. You want to prevent people from developing the disease, and you want to see that people who have the disease have access to effective treatment. Those are the two most important things, and you have to do both. Supply control is extremely important as well, and sometimes when people hear the term supply control, they think about the war on drugs, which I think the war on drugs may understandably has a bad reputation because it conjures up the image of locking up tens of thousands of people who have the disease of addiction in prisons, which I don't think is an appropriate way to handle people, to treat people with this illness. But controlling the supply is important. And I think the best example of why it's important, that I can come up with comes from here in New York City when New York City, probably more than any place else on the planet, has been very effective at reducing cigarette smoking. And one of the things that we did that was effective was we made cigarettes extremely expensive. I'm not sure how much cigarettes cost in Canada, but here in the United States, cigarettes in New York City are more expensive than any place else. It's about $13 for a pack of cigarettes. And by making cigarettes more expensive, the other thing we did was to give out nicotine patches for free. By doing those two things, we were able to encourage many New Yorkers to quit smoking. So controlling the supply is important with opioids as well, because it's very difficult to treat people with the disease of opioid addiction if they can very readily access a pill mill or a pain specialist. And sometimes the distinction between pain specialist and pill mill is a lot fuzzier than you might think. I'm an addiction specialist. I treat people who are opioid addicted. I don't know how I'm supposed to treat a young adult who's addicted to oxycodone when that young adult can march into a pain specialist's office and walk out with 240 tablets of Percocet. How am I supposed to treat that individual? And that's going to be a young person who's going to be very high risk for drug overdose death. My organization is very interested in better regulation of opioid manufacturers. One of the ways we feel that our Food and Drug Administration can do that would be through changes in the labeling on opioid analgesics. The labels right now say that opioids are indicated for moderate to severe pain, which gives drug companies a license to market opioids as if they're safe and effective for whatever condition that causes moderate to severe pain that they want to market it for. And because our label has no specific instructions with regard to dose, drug companies are also allowed to market high-dose opioid therapy. So we'd like to see more specific indications, more specific instructions on opioid analgesics so that we could prevent drug companies from putting out advertisements like this, but also from sending their drug reps, their sales force, in and out of doctors' offices, encouraging them to prescribe opioids for chronic pain. As I mentioned a few times now, the CDC is telling us that overprescribing of opioids, that green line going up is causing this crisis. We think it's going to be very difficult to make that green line go down if our Food and Drug Administration continues to allow drug companies to encourage doctors to prescribe opioids aggressively, to do everything they can to make that green line go up. These are listed here are just a few interventions that are commonly discussed. I mentioned the opioid label changes that my organization is focused on. You'll hear lots of talk about tamper-resistant formulations. Tamper-resistant formulations are pills that are harder to, that you can't, or that are made harder to crush and snort or crush and inject, or if they're an extended release pill, that they're more difficult to chew and get the entire dose at once. We think that all opioids should have tamper-resistant formulations, and that technology doesn't need to be fancy and expensive and patentable. There are very inexpensive ways of making painkillers tamper-resistant. At the same time, we're concerned that tamper resistance is being seen as a panacea to this epidemic. And while we think it would be good if all opioids had tamper resistance, and it might help reduce some rates of injection drug-related diseases like hepatitis C, might help reduce some overdose deaths, we think the overall impact of tamper-resistant formulations is likely to be small, because a pill that's harder to crush is not a pill that's less addictive. And many people, certainly almost everyone who develops the disease of opioid addiction, starts off by swallowing their pills whole. People who move on to snort their pills or inject their pills typically have already developed the disease of addiction. And if we're going to bring the epidemic under control, we need to create less new people with this disease. Tamper-resistant formulations don't help us do that. And in fact, if drug companies are permitted to market tamper-resistant formulations as if they are less addictive, that could actually give doctors a false sense of security and encourage prescribing, encourage that green line to continue going up and make this drug and make the epidemic worse. Prescription drug monitoring programs, these are databases where all of the patient's prescriptions are entered. And here in the United States, we're beginning to give doctors access to these databases so that they can see if their patient is doctor shopping, getting prescriptions from multiple doctors, which would be pretty good evidence that the patient might be addicted. These are good interventions. And here in my state, we passed a law requiring our doctors to use our database before prescribing a controlled substance, and that law is going to go into effect this summer. And we think that use of these databases should be made mandatory, because if it's not mandatory, there's good evidence from states that don't make it mandatory that very few doctors take the time to check. At the same time, though, despite the fact that we think this is a very effective intervention and it should be made mandatory, it's important to understand that prescription drug monitoring programs, again, in themselves are not going to help bring this crisis under control, because they also don't help us prevent people from developing the disease of addiction. People who are doctor shopping already have the disease of addiction, and one of the more effective interventions that can come from use of a PDMP would be if we use them to link patients who are doctor shopping to addiction treatment. Unfortunately, there's very little action on that front. The state of Nevada came up with an intervention where they did that, but very few states are looking at ways of linking their doctor shoppers to addiction treatment. And of course, another very good use of a prescription drug monitoring program would be used to identify doctors who are prescribing in a risky fashion and either giving them better education, taking their license away, or if they're prescribing in a criminal fashion, prosecuting them. And all of which could be helpful in bringing the epidemic under control. I'm going to finish up on this slide, and I'm showing this slide to explain why it is that this epidemic has continued to worsen over the past decade with very little proper intervention from policymakers, both in the United States and in Canada. And I think that the reason there's been little appropriate action is because policymakers have had the problem framed for them in this fashion. If you see in the middle of this slide, the person trying to balance themselves is the policymaker. And the policymaker is told that they need to find the right balance between drug abusers and pain patients. And they're told that we have these two populations and don't come up with interventions designed to reduce drug abuse that will make pain patients suffer. Don't make the pain patients pay the price for the bad behavior of the drug abusers. and that you need to come up with balanced interventions that don't affect patient access. And I think that's a completely inappropriate way to frame this crisis, because what we know is that we don't really have two distinct populations. There's really a tremendous amount of overlap between these populations, and that when you look at chronic pain patients on long-term opioids, you find out that more than half will acknowledge that they're using their opioids for purposes other than pain. In a recent study, 35% of patients, chronic pain patients on opioids, met criteria, DSM-5 criteria for addiction, which we call opioid use disorder now, going into DSM-5. And 92% of people who had died of opioid overdose deaths, in a recent study coming out of Utah, they found that 92% of these individuals had been receiving their opioids for a diagnosis of chronic pain. So there really is tremendous overlap between these populations, and more cautious prescribing, making sure that our medical community appropriately understands the risks and benefits of opioids, will disproportionately benefit people suffering from pain, since this is a population that's most at risk right now for the harms of opioid overprescribing. Thank you very much for taking the time to listen to this webinar. I would encourage you to visit our website, and you don't have to be a doctor to join PROP. There are places on our website where you can sign up and get on our mailing list, and you can also follow us on Twitter. The Twitter is @supportprop. Thank you very much.